For the next speaker, it's my pleasure, and Tom will be able to to introduce Dr. Wilson Kwong. Wilson is an associate professor of medicine at the University of California, San Diego, and leads our pancreatic or pancreatitis center and deals with a lot of referrals from all over the Southern Cal region in terms of pancreatic necrosis, pancreatic fluid collection. So Wilson was unable to join us in person here today, but will be speaking via Zoom. So Wilson, thanks for joining us.
All right, thank you, Tom, and thanks to the organizers of LA Live for inviting me to give this talk. All right, so I'll be talking about the management of peripancreatic fluid collections today. I'm going to go over some studies that came out over the last year that I think answer a lot of important questions that we've had in the field. No relevant disclosures. So one of the more important questions relating to pancreatitis in general is how do we resuscitate patients? You know, we don't have a therapeutic or a medical therapy for pancreatitis at this point, and so we think that how we resuscitate patients can have an outcome, change in outcome down the road. And so this was the waterfall trial, which was presented at DDW just a month ago. Dr. Buxbaum, who's also here, was one of the authors on this really important study. This was a multi-center RCT with 18 centers, most of them in Spain, and it studied aggressive versus moderate goal-directed fluid resuscitation for pancreatitis. Patients were randomized within 8 hours of their pancreatitis diagnosis, so they got to them pretty early. And in the aggressive arm, they were given lactated ringers at 20 mLs per kilo bolus over 2 hours, followed by 3 mLs per kilo after that. And so for your typical 100-kilo overweight pancreatitis patient, this is a 2-liter LR bolus, followed by 300 cc's an hour. In the moderate arm, they got 10 mLs per kilo bolus over 2 hours if they were hypovolemic. If they were felt to be euvolemic or normovolemic, they didn't necessarily receive a bolus. And this was followed by 1.5 mLs per kilo. So this is a 1-liter bolus if they're hypovolemic, followed by 150 cc's per hour, which is similar to maintenance fluids that we would give. And the primary endpoint was moderate to severe pancreatitis as defined by the revised Atlanta. They ended up including 249 patients. In the aggressive arm, they got a median of 7.7 liters of LR, and in the moderate arm, they got 5.4 liters. After the interim analysis, the study was halted due to differences in safety without much difference in efficacy. And so it seemed that the aggressive arm actually had a greater degree of fluid overload, which probably is not so which may have been a little bit surprising. And there was also greater length of stay in the aggressive group, an average of 6 days versus 5 days, and that did reach statistical significance. And I think this is a very important study. So probably says that we should be targeting euvolemia and trying to avoid hypervolemia. And I think that this probably should affect our everyday practices, and especially in patients who have heart failure, CKD, or liver disease or ascites. Maybe we don't need to be very aggressive in resuscitating them. And if patients are euvolemic or even hypervolemic when they come in with pancreatitis, one of the questions is, do we need to even give them any fluids? Another important question is, when do we drain? This is the Pointer trial from the Dutch pancreatitis group. This was published in the New England Journal in the last year. This was studying immediate versus postponed intervention for infected necrotizing pancreatitis. And this was a comparison of immediate versus delayed drainage. This was a multi-center RCT, as the Dutch pancreatitis group does so well. This took place between August 2015 and October of 2019. They ended up recruiting 104 patients. And so when I first heard about this study, a few years ago, I thought, well, this is great. We're going to see data where we drain people within the first 1 to 2 weeks versus patients who are drained between 6 and 8 weeks. But sorry, let's see.
And I think we were some of your slides got frozen on us.
Okay. Can you see them now or no?
No, we just see you, but you're looking good.
All right. It's not quite as good.
It froze at the waterfall part.
Okay. Can you see it now?
It says it's starting to share. It hasn't shared yet. And Tom, I don't know if we have the slides on, on our computer. We can just have him talk through that as well.
Try it again, make sure you share the screen.
Yeah. So I'll just keep going and hopefully you guys can kind of bring up the slides.
And Wilson, we were saying maybe stop sharing for one more time.
Yeah.
And then maybe try it again. There it goes. Now we can see the waterfall trial slide.
Okay.
Oh, maybe that's
if you guys just want to do this, I can just tell you when to do the next slide.
Yeah, so it's advanced slide.
Let's advance a little bit more. Let's keep going there. One more over. And probably another two.
Okay.
Okay, and keep going.
Great. And Wilson, you can just say next each time you want them to advance it. We'll be good.
Next. Yep. Yeah, and so how the study kind of randomized patients and determined the timing for drainage was really important here. And so in the immediate drainage group, patients were randomized to catheter-based drainage by IR within 24 hours once infected necrosis was diagnosed. Within the first 2 weeks, they required a diagnosis of infected necrosis based on gas within the collection or a positive fluid aspirate, and neither of those happen all that frequently in clinical practice now. After 2 weeks, they allowed for persistent signs of inflammation and fever to be the criteria for infected necrosis. And so the patients in the immediate drainage arm actually got a drainage at a median of 24 days. Patients who were randomized to the postponed drainage arm, they got their drainage once encapsulation occurred. And this ended up being a median of 29 days. So you see the difference was about 5 days if you look at the median time to drainage. If you looked at the average, then it went up to 10 days, but still it's kind of not as big of a difference as I had initially hoped when I heard about the trial. Next. And so these are the secondary and primary endpoints. So their primary endpoint was a complication index score. That was initially developed to look at post-surgical complications, but it weights all the different complications based on severity. And there was no clear difference based on the rates of complications. So if you look at the individual complications in the secondary endpoints below, they're all pretty much similar, including death, organ failure, bleeding, perforation, fistulas. And so kind of the summary of this slide is there's no big difference in the complications, whether you do early or delayed drainage. Next. The biggest difference, and probably the most interesting difference, is the need for procedures and especially necrosectomy. You can see that the need for necrosectomy was much higher in the immediate catheter drainage group. 51% of patients needed drainage compared to only 22% in the postponed catheter drainage. So these patients were getting more invasive procedures. If you look at the top above the red box there, you also see catheter drainage. Of course, the immediate catheter drainage, 100% of them received drainage because that's the protocol. But if you looked at the postponed group, only about 60% of patients required catheter-based drainage, which means about 40% of patients were managed successfully with antibiotics alone or with conservative therapy without any drainage or necrosectomy. And so we are able to manage a fair amount of patients without any drainage, even if they are suspected to have infective necrosis. And you can see when you look at the total number of procedures required for drainage, whether surgical, endoscopic, or catheter, the immediate group had a much higher rate, 4.4 procedures versus 2.6 procedures. Next. And so again, kind of the takeaways were that you can manage a significant amount of people with just antibiotics alone and don't necessarily require drainage. Maybe these patients didn't truly have an infection, but in either case, they were able to avoid drainage. And immediate drainage didn't clearly result in better or worse outcomes. And I think that there's still a role for early drainage. Certainly, it's not something that we should do on a routine basis. But in patients who are deteriorating, critically ill, they're crashing and burning despite getting antibiotics and maximal medical therapy, I think there's still a role for early drainage. And it shows that there's not clearly worse outcomes when you have to do it early, but you just have to be prepared that they will probably require several procedures, including necrosectomies. But if they're not responding to medical therapy, they're kind of already declaring themselves to be on the sicker side. Next. So another important question is, how do we drain? Next. And so this was the Prometheus study. This was also from DDW just a month ago. This was a randomized trial studying plastic pigtail drainage of walled-off necrosis versus LAMS EUS drainage. This was another multi-center RCT done in Spain. This took place from 2017 to 2019. The primary endpoint was short-term clinical success, which means that the collection decreased by 50% or went down to less than 5 centimeters. Next. And so they were able to recruit 61 patients for the study, about 30 in each arm. There seemed to be trends, but not everything reached statistical significance. So there was a trend towards increased clinical success in the LAMS group, but that didn't hit statistical significance. And then the procedure duration was clearly shorter, 38 minutes versus 53 minutes in the LAMS group, which is not surprising. Next. And so there were a trend towards additional and rescue procedures in the double pigtail group, but again, that was non-significant. Length of stay and adverse effects, again, were not that much different. And so, with this trial, certainly recruiting 60 patients for a trial of this type is very difficult. But I think that we would have liked to have seen, at least based on some of our clinical experience, that there was a need for decreased necrosectomy, a need for decreased procedures, or maybe a faster resolution in the LAMS group compared to the double pigtail group. And although there were trends, I think that maybe if there were similar future trials, or we can get a meta-analysis in the future, that we might start to see these differences. But for now, based on this trial, there's not a clear superiority of the LAMS group. And maybe this is more of a convenience issue rather than a necessity for LAMS right now. And I think that, the other take home too is, if you have somebody who's experienced and who's good at drainage and necrosectomy, I think your outcome can be good either way, whether you use pigtails or LAMS. Next. And so, when LAMS first came out, there was a question about safety, especially when it pertained to bleeding. And so the next study is a retrospective study, but it kind of gives us a lot of a large retrospective series regarding its safety. Next. Next. And so this was a retrospective study out of 18 centers in UK and Ireland, and they got about 1,000 patients across multiple centers. And I just wanted to highlight the bleeding risk. So they demonstrated a 1% immediate bleeding risk, which was defined as within 24 hours. And then a 1.9, or kind of around a 2% delayed bleeding risk, which is defined as after 24 hours. And so these numbers are a lot more reassuring compared to some of the really early studies that we saw. And I think that, this it's also nice that this kind of represents more of a real world experience, since not all of these were academic centers. There was a lot of community centers as well. And so even with a variety of different centers doing this, the complication rate seems pretty low. And the buried stent rate is around 5%. So I think that's still something significant that people should be aware of, especially if you do a lot of this. The adverse events also didn't seem to be associated with dwell time. I know there's also a lot of focus with kind of getting the LAMS out early. And certainly that's probably still a good thing, but a lot of our patients will have a lot of necrosis and it'll be difficult to get out, and you can't always get the stent out within 4 weeks. Sometimes you do need several sessions of necrosectomy and kind of pulling out the stent and maybe placing new ones. That is going to add more cost. So if you can leave the lambs in a little bit longer and do it so safely, then I think there's a benefit in that. But I think it's just, the bottom line is still take out the lambs whenever you're done with it. But it doesn't necessarily mean that we have to get it out within a month or within a couple weeks. Next. Another question that a lot of us deal with is the possibility of a disconnected pancreatic duct after we're done doing the necrosectomy. So, once we're done with the necrosectomy, we feel like we've done a lot of work and, kind of the hard part is over. Next. And so this was a study out of Dr. Reddy's group looking at whether pigtail stents are helpful to prevent further complications related to disconnected pancreatic duct after you take out your lambs. Next. And so, probably, based on previous retrospective studies, we think maybe about 50% of patients have disconnected pancreatic duct, although, based on the data here, it could actually be higher. And so they also, this study showed that a disconnected pancreatic duct was also associated with the recurrence of fluid collections as well as new onset diabetes. But the actual risk of need for intervention was low, even if there was a recurrent fluid collection. Next. So they had, this was a single center retrospective study, and they had 274 patients with walled-off necrosis. They were all drained with the Nagy stent, which is similar to the Axios, except a little bit longer. It's a large caliber metal stent. The study took place between 2013 and 2017. And one of the strengths of the study is they did MRCP and ERCP in almost all their patients. And by doing that, they found disconnected pancreatic duct in 73% of patients. Next. So that's a fairly high rate, probably higher than was appreciated in previously studies, but that could have been because they were doing ERCP and MRCP in every patient, so they were getting a really thorough evaluation. Recurrent collections occurred in about 13% of patients, and the majority of cases were in patients who had disconnected pancreatic duct. So pretty much all of them had disconnected pancreatic duct who had collections reaccumulate, but reintervention was only necessary in 6% of patients who had symptomatic recurrences. So that's pretty low. Next. And so with the low rate of recurrence that were symptomatic, they said they probably don't need plastic stents, pigtails placed after you remove your lambs. Next. And so the same group followed this retrospective study up with an RCT. They got 104 patients, and this happened in the 3 years after the retrospective study. They confirmed disconnected pancreatic duct again on MRCP and ERCP. Nagy stent again was used for initial drainage. And then patients were randomized to either 1 or 2 7 French stents versus no stents after their stent was removed. Next. And so they really didn't notice a difference in the rates of recurrent pancreatic fluid collections between the 3 groups, and they followed the patients at 3, 6, and 12 months, and there was also no difference in the need for intervention either. And so kind of what this tells us is that this gives us some data to feel good about not leaving pigtail stents. I think a lot of us are leaving pigtail stents after we remove our lambs just because we really don't want to intervene on these patients. We feel like we've done the hard work already. We've cleared the necrosis. Last thing we want to do is have to come back a few months from now and have to redrain a pseudocyst that reaccumulates. But I think that this is pretty good data. It makes us a little bit braver, and probably I'm going to stop leaving pigtail stents and kind of follow my patients now. So I think that this study does change our practice, and it's probably going to change my practice. Next. Okay, and now what about the gallbladder in patients with necrotizing pancreatitis? When do we take that out? Next. And so this was another study from the Dutch pancreatitis group. This one was not an RCT though. This was a post hoc analysis of patients from multiple clinical trials. And so they were looking at what is the optimal timing to do cholecystectomy after necrotizing biliary pancreatitis. They took patients from their trials, Panther, Python, and Tension. These were the Panther was the step up trial. Python was the early enteral feeding versus on-demand oral diet. Intention was the endoscopic versus surgical step-up therapy. So they took patients from these studies. Next. And so since they were 3 clinical trials, this took place over a decade, 2005 to 2014. They had a total of 248 patients with necrotizing pancreatitis due to biliary etiology. About 3/4 of them underwent lap chole, and that happened at a median of 100 days after discharge. Next. And so they looked at complications at various time points, 2 weeks, 4 weeks, 6 weeks, 8 weeks. And around the 8-week point, the complication rate seemed to be significant between the arm that got their lap chole and who didn't get their lap chole. And so they said that before 8 weeks, right around 8 weeks is probably the optimal time to take out the gallbladder. If you looked at overall biliary complications, the differences in biliary complications started to become significant at 10 weeks, but they chose to kind of go with 8 weeks. And that's kind of what the guidelines say now, around 6 or 8 weeks after biliary necrotizing pancreatitis, when we've got the infected necrosis under control, it's probably a good time to take out the gallbladder. And so this probably doesn't change our practice a whole lot, but it's nice to have data to kind of support the guidelines that are in place now and know that kind of we're probably doing the right thing. Next. They also looked at complications of the cholecystectomy. A lot of our surgeons will tell us that they don't want to go in right now because it's going to be a difficult cholecystectomy, and I don't doubt that that's true. But does waiting make it an easier cholecystectomy? And they looked at a host of post-surgical complications, including biomas, abscesses, infected necrosis, bleeding, adhesions, gallbladder spillage, conversion to open, a subtotal cholecystectomy, and need for drain. And these were not different at various time points, especially waiting a couple months didn't really make it an easier surgery in terms of complications. Also, sometimes we'll get asked by surgeons to perform an endoscopic sphincterotomy with ERCP if they're not going to get their gallbladder out, hoping that that will decrease the rate of biliary complications while they're waiting for their lap chole. And that didn't seem to be the case. So I don't think that there's any evidence to support that doing a sphincterotomy just to help prevent future complications is really supported at this time. Next. Next. And so these are just some of the new devices that have kind of come out in the last year or so that can kind of help us in kind of what we do in terms of draining necrosis and managing pancreatitis. So long saddle for Axios came out, the 15-millimeter long lamb stent. And there were studies that said that we could successfully and safely drain collections that are more than 10 millimeters away. There's also another electrocautery enhanced lambs coming out as well with similar outcomes to hot Axios. We have the 6 and 8 millimeter hot Axios now, which is probably more helpful for pseudocysts, probably not for necrosis, but given the small size. However, that might be helpful in patients who have small GI tracts, whether you're doing it through patients who have had gastric bypasses or maybe Whipple's post-surgical anatomy. Having the smaller internal flange is probably nice. And then the endorotor as well seems to be efficacious. That's the necrostectomy device that gives you irrigation and suctioning as well, and seems to speed up things. And it seems to have an acceptable side effect profile as well. All right, next. All right, thank you very much.
Great. Really, it's amazing how the whole field has changed in terms of managing these pancreatic necrosis and fluid collections. Just for the audience and those on Zoom, we will actually be seeing live demonstrations of pancreatic necrosis, pancreatic cyst aspiration, and FNA of pancreatic masses just after these presentations.